Ravi, can you make it full screen, Kanna?
Yes, sir. Sir, is it visible?
Yeah, you're good. We'll have another 1.5 minutes to go. We'll start. So, warm welcome to all of you. First of all, as Dr. Rajiv Sahai sir has message, today is a very special day and a lot of people have good ranks and we've been getting message. Congratulations to all of you. And we are proud to share that PG clinics have also achieved a great feat of having 6,75,000 views of postgraduates across the country. And we have also crossed 19,500 subscribed members for the PG clinics. And thanks everyone for making it a possibility week on week. So without much ado, we move on to the evening discussion. And Dr. Venkatrami Reddy sir will be joining at a little tad. So we have the PG resident. Kanna sir, good evening, sir. Srinivasan sir, good evening, sir.
Good evening, sir.
Good. So we have the postgraduate, Dr. Ravi Teja Reddy, kindly contributed by Professor L. Sridhar, Apollo Institute of Medical Sciences, Hyderabad. Thank you, Sridhar sir. Sridhar sir will be joining in 5 minutes. That's what he has messaged me. So today we have one important exam case, which will be mass abdomen. Definitely either you give a DNB or MS exam. If there is a mass abdomen, it will be kept. Welcome, Sridhar sir. Thank you for joining.
Thank you, sir.
So we have a very eminent invited faculty for the day. We have Professor Venkatraman Reddy sir from Sri Venkateswara Institute of Medical Sciences, Tirupati. Vamsi Krishna sir from Narayana Medical College, Nellore. Professor Vaibhav Sutaria from Ahmedabad. And Professor Shankar Subrayan from Trichy Government Medical College. We have a panel of surgical gastroenterologists to have a discussion on. So I also warmly greet the people who have joined on YouTube. And I invite Dr. Ravi to present his case. All the faculties are been with us earlier, so they know the routine. The candidate presents till the end of the discussion, clinical part, and then they move on to the go back to the slide and the discussion begins. And after that, the candidate is allowed to go to the clinical side, and then the rest of the discussion happens. Normally, we have about an hour for this case discussion. So I request the examiners to give the right answer if the candidate finds difficult to answer. I guess some of you have joined in two devices. I request all of you who have joined in two devices to kindly log out in one of the device. That will avoid the feedback and other issues. Thank you very much. Ravi, good luck to you. Best wishes.
Thank you, sir. Good evening, esteemed faculty. I am Ravi Teja, a final year postgraduate of General Surgery Department, Apollo Medical College, Hyderabad. I am mentored by my HOD and professor, Dr. L. Sridhar. Today, I'm going to be presenting a case of epigastric lung. A 40-year-old married woman, housewife residing in Hyderabad, presented with following chief complaints of recurrent abdominal pain since 1 year, fullness in abdomen, and early satiety since 3 months. The history of presenting illness. Patient was apparently asymptomatic 1 year ago. Then she developed upper abdominal pain, which was sudden in onset, severe stabbing type, radiating to back, aggravated on binge alcohol intake and food intake, relieved partially on bending forward and taking medication. Since 6 months, the severity of pain increased, and her recent episode was 15 days back, which was associated with non-projectile, non-bilious vomiting with food as content, with 1 to 2 episodes per day. History of multiple hospitalizations for pain, which was managed conservatively over last 6 months, was present. She noticed a small area of fullness in upper abdomen since 3 months ago, which gradually progressed to present size. From last 3 months, her diet was reduced from 4 chapatis per meal to 2 chapatis per meal, with postprandial fullness after meal. History of decreased appetite, and she lost 6 kgs in last 1 year. There was no history of LOS, discoloration of eyes, pruritus, or dark colored urine. There was no history of hematemesis. There was no history of melena or pale colored stools. There was no history of trauma. There was no history of steatorrhea. There was no history of any visible peristaltic movements in the upper abdomen. Past history, no similar complaints in past. She is not a known case of diabetes mellitus, hypertension, or tuberculosis. There was a history of tubectomy 10 years ago. Family history, no cancer related deaths in the family, no similar complaints in the family scene. Personal history, she consumes mixed diet, appetite is decreased, bowel habits were irregular, bladder habits were normal, sleep was disturbed due to pain. Addictions, she used to consume alcohol for past 10 years, around 100 to 120 ml of whiskey per day, for 4 to 5 times per week. She's abstained from alcohol for past 3 months, and she's not a smoker. Menstrual history, age of menarche is 12 years. She has regular cycles with 30-day cycles and 3 days of bleeding. Obstetric history, she's para 3, living 3, abortion 0, full term normal vaginal deliveries. Summary of history: a 40-year-old female, chronic alcoholic with no known comorbidities, history of recurrent severe epigastric pain radiating to back since 1 year with frequent hospitalizations, has developed upper abdominal fullness and early satiety for past 3 months, associated with non-bilious vomiting since 15 days, with no future suggestive of obstructive jaundice or upper GI bleed.
Okay, Ravi, good evening. Let's go to your first slide.
Good evening. Yes.
No, right in the beginning. A good surgeon pays attention to his name, right? You can't write Ravi with small t and small. It just shows lack of concentration, right? You get it? Can you hear me, Ravi?
Yes.
What could be a probable diagnosis?
It would be an upper abdominal masses, since she has symptoms of abdominal fullness and early satiety.
Now, upper abdomen is too much.
Yes.
Which organ?
Arising from, yes, sir. The pathology may be arising from around the stomach, sir.
Why do you say stomach?
Sir, because stomach or duodenum. Because since the vomitings were non-bilious, and the patient is complaining of early satiety and abdominal fullness after consuming foods. That means her storage capacity has decreased.
Ravi, you've got two symptoms. You've got a vomiting and pain, and you've got a lump.
Yes, sir.
Now let's come to your differential. Lump upper abdomen with vomiting and pain. What could it be? What are the differentials?
It could be a yes. it could be a mass arising from the pylorus of the stomach, or it could be a pedunculated left
No,
hepatic
pylorus from the
mass.
mass, pylorus also you get pain.
Yes.
Give us something which has all three things here. You have pain, you have vomiting, and if you get a lump.
Actually, at
this
this stage,
this is what happens when you know the diagnosis.
Yes.
actually at this stage you
Gallstones would be a
cannot
common cause
describe.
here. Right. So please.
Actually, at this stage, you cannot describe anything about the mass because it is only the history. You have just
Yes.
completed your history. You have not yet started your inspection or palpation or anything returning to the clinical examination.
Yes.
So
Yes,
you have to
yes, sir.
abide
Probably.
only with the history, what it says, and what you are about to do. That's all.
Yes.
Probably, yes.
One moment, sir. Abhay, sir, would you like to ask something, sir? I saw your hands go up.
Yeah, I just want to ask this candidate,
Hmm.
which are the lump in the epigastric region with
Yes.
pain in epigastric region radiating to the back and causing obstructive symptoms?
Sir, it can be a peptic ulcer disease, sir. Sequelae of peptic ulcer disease.
What is the sequelae of peptic ulcer disease that gives rise to this complication?
Sir, cicatrization of the ulcer can have the similar
What are the
complaints.
complications of what are the complications? How do you classify complications of peptic ulcer?
Sir, perforation and hemorrhage, GI hemorrhage, sir.
So either of these two will not give rise to these complications.
Yes,
So
sir.
what is the third subacute complication which can give rise to this sort of problem? If you say, I don't know, I will be happy.
Sir, maybe acute pancreatitis sequelae.
Now you are going to pancreatitis from ulcer.
Yes.
What complication related to duodenal ulcer can give rise to these symptoms in a patient? That's why I said subacute.
Gastric
It is
outlet obstruction.
no, it is perigastric abscess. Forget about it because I
Oh.
think your diagnosis is something different. Go ahead. Let's go to pancreas.
Okay, Ravi. Now
Yes.
that Sir told you. Look, you have to think the patient has history of alcohol, chronic alcohol intake,
Yes.
right?
Yes.
She has history of multiple admissions.
Yes.
She has history of typical pain radiating to the back,
Yes.
right? And she has, when does a pseudocyst usually form after pancreatitis? After how many days usually?
After 4 weeks, sir.
Yeah, so she's got it
Acute
after that.
pancreatic collection will turn into
Right.
pseudocystin.
So all of this you have to take by your history. You know that it could be probably be a pseudocyst.
Yes.
But what could be the other causes, other things which are causing the same thing?
Yes.
So come up with them now.
One more thing, do you have a proper past treatment history of this patient? Because you have mentioned that the patient has multiple hospitalizations. So do
Yes,
you
sir.
have any detailed detail about that past history? What is the admission? How many times she got admitted?
Yes. How
And
long was she admitted?
how long she was admitted?
what was done?
What was done?
Yes.
Whether she was
The
kept in NPO or she was on an enteral diet from the start and she not having any other complaints. And what are the drugs given? Because nowadays patients are coming with all the electronic documents in their hand. So did
Yes.
you check in that? Did you check in what is the blood investigations done? Is there any imaging done at that time? And what has been prescribed for the patient like this?
Yes, sir. I inquired about the history, sir. The history she has given is she got admitted into the local hospital and she was treated conservatively with painkillers and antiemetics.
No, that's
That's the
fine.
only significant history she has.
Each time she was admitted in the same hospital.
I didn't answer.
Was she admitted to the same hospital during each episode? Or does she know her diagnosis?
No, sir.
Okay, that's fine.
So she
So-
knows that it is a sequelae of consuming alcohol, but she doesn't.
Okay, that's fine. Why don't you think of gallbladder with stones, gallstones?
Yes, sir. But she doesn't have. Yes, sir. It can be acute calculus cholecystitis.
Repeated biliary colics.
Yes.
Okay.
Yes.
Even
Can you tell what are
gallstones can
the
lead to
The
various
classical description of pain was severe stabbing type instead of colicky type of pain, sir. Crescendo, decrescendo type of pain.
what are
Brinj
the various
alcohol intake.
lumps which can arise from the stomach?
Sir,
What are the various lumps which can arise from the stomach?
uh, it can there can be polyps, sir. There can be cancerous mass. There can be maltoma.
You should tell like intraluminal.
Fundic polyps.
Yeah.
Intraluminal,
Yes.
mural, and extramural, है ना?
Mural,
Yes.
extramural.
Yes. Sir. Yes.
Yeah.
Sir.
So tell
Gist
about
can
the
be-
extramural masses which
Yes, sir.
is
Gist
exophytic
can be-
variety. Exophytic variety, but presenting as a lump.
Gist can be there.
Hmm?
Gist.
Gist. Yes.
Gastrointestinal stromal.
Right. Yes, gist is there. Yes. Then tell about the luminal one.
Luminal fundic polyps can be there, sir, which are
But usually polyps
hematomatous.
will not be palpable. No? The patient will not present as a lump in
Yes.
that. No?
Yes, sir.
But in which condition the patient has a luminal mass presenting as a lump?
Bezoars can be there, sir.
Bezoars can be
Foreign, yes, sir.
Yes.
Foreign body.
there. And then from the mural, no? It can be malignancy or lymphoma, or it can be tuberculosis, or it may be peptic ulcer disease, no? Distended stomach, which is there.
Oh.
Okay.
Okay. So let's yeah, okay. Hang on. Yeah.
Oh.
History of present illness. So she developed pain on sudden onset, severe stabbing, radiating to. Why does it radiate to the back? Pancreatitis.
Sir, sir, if we talk about pancreatic pathology, due to acute inflammation, there can be exudation of the chemokine, sir, which irritate the celiac plexus, due
Okay,
to
fine,
which
fine. Okay, that's fine. Why does a binge of alcohol precipitate pancreatitis?
Sir, alcohol is directly toxinogenic to the pancreatic parenchyma, sir. It causes free radical injury and it causes a lysosomal and zymogen granules fusion, because of which SNR cells
Right. Okay,
gets
that's fine.
destroyed.
Bending forward and taking medicines. Okay, next slide, please. 6 months, recess, 15 days back. Okay. What about vomiting? Why does vomiting happen in pancreatitis?
Vomiting due to pain, there can be sympathetic system stimulation and
Okay, one is pain.
pyloric
Other reason?
spasm.
Yeah, pyloric spasm and with edema. Right.
Yes, yes.
Okay, last 6 months. Next slide.
Is she a recent onset of diabetic?
No, sir.
No.
Yeah, no, sir.
Have you checked? Have you checked?
Yes, sir. Yes, sir. We have checked.
Yes.
Because you said pancreas is injured
Yes, sir.
due to diabetes,
Actually, it takes a long history for the patient to land in endocrine and exocrine insufficiency.
Okay. Don't get panic, Ravi. Just ask.
Should I change?
Okay. Right. No. Hang back. Just go back.
Oh.
Why is there postprandial fullness after meals? You just write postprandial fullness after meal. Of course, and just after meals. It should just write postprandial fullness.
Okay.
Yeah, why does that happen?
It can be due to functional causes like dyspepsia, or it can be due to any external compression on the stomach.
That's fine. That's fine. Just give me.
Okay, sir.
Can I come in?
Yes, sir.
So you have a patient who is an alcoholic, who has
Yes, sir.
pain in the epigastric region radiating to the back, indicating that there is something to do with pancreas.
Yes, sir.
Now you have this patient extending into obstruction
Yes,
above
sir.
the level of the papilla,
Yes, sir.
leading to non-bilious vomiting.
Non-bilious. Yes,
You
sir.
agree?
Yes, sir.
Yes. So, based on the history, what would be your primary diagnosis?
Uh, Based on the history, it can be either due to an acute a sequelae of acute pancreatitis or chronic pancreatitis, leading to
Fair enough.
formation of
Fair enough.
pseudocyst
Fair
or
enough.
Waldorf necrosis.
1 minute. 1 minute. Now you are talking too much. So
Yes,
let me ask you, what is Atlanta classification of acute pancreatitis?
yes, sir.
Your diagnosis is
In two,
pancreatitis.
yes,
Dr.
sir.
Khanna has asked you about stomach. I agree with
Yes,
him. And,
yes.
let us go into further discussion how your thinking should go based on the history.
Okay, sir. In 2012, Atlanta divided pancreatitis into four sequelae, sir. One is acute intestinal
There is a
edematous
further
pancreatitis.
modification of this Atlanta classification. Can you tell me something about it?
No, sir. I only know four.
Doesn't matter. Doesn't matter. Doesn't matter. Do you think this is acute interstitial pancreatitis or it is necrotizing pancreatitis?
Sir, I believe it is acute interstitial edematous pancreatitis.
Then it should resolve. It's going on for how many years now?
So 1 year, sir.
1 year.
Yes.
So how much time does it take for acute interstitial pancreatitis to resolve?
But there were recurrent attacks because of her alcoholic consumption.
No, don't blame her. Don't blame
Oh,
her.
okay, sir.
She
Sorry.
has presented to you at a present condition.
Yes, sir.
And you have to, at present, know what is the condition of the patient and, decide treatment.
Yes, sir.
Yeah. So
For
anyway,
acute intestinal edematous pancreatitis to resolve, it takes around 2 to 3 months, sir.
I don't agree with you, but it's okay. Fair enough. Let's go ahead.
Okay.
Now, will acute intestinal pancreatitis produce obstruction or chronic?
Acute, yes, sir. If there is a formation of pseudocyst, or if the head portion of the pancreas is involved, it can cause a duodenal obstruction, or a pseudocyst can cause obstruction of
Per,
duodenum or stomach.
per se, it will not cause. Only when it's
Okay,
chronic pancreatitis, it will cause.
okay, sir.
Okay.
Okay, Tejas, one question then. Continuation.
Yes.
Cirrhosis is more common in acute pancreatitis or chronic pancreatitis?
Chronic pancreatitis, because there will be formation of strictures and
Good, great. Okay, next slide. Just write no history suggestive of obstructive jaundice. Just MBBS, don't
okay.
give us result.
Okay, sir.
GI
Yeah.
bleed,
Yes.
trauma, steatorrhea. Okay, VHP. Next. Of course, what do you mean past? She's been
patient
having
was not.
repeated past
Yeah,
means
patient was.
of this
Yes.
episode, she's been having episodes before now. So you must write
Yes.
she's been having multiple episodes of admission.
Okay, sir.
It's not the
As
first
this
time
is
she's coming.
continuous pathology, I wrote it, sir. But I'll.
Okay. Yeah, I think that. Just right, not known case of all this comorbid cystitis as medical history.
Okay.
Tubectomy. Right. Next slide. Cancer-related deaths. Which cancers are you looking for?
Sir, pancreatic cancer, breast cancer, stomach cancer, and ovarian cancer.
Colon.
Any other thing you want to ask in the family history? Any other thing other than
Uh,
malignancy?
no, I'll ask whether similar complaints were present in the family because familial pancreatitis involving PRSS gene and SPINK1 gene
No,
can
hang on.
be.
Don't go that far.
Okay.
Something more common. Something more common. What are the causes of pancreatitis? You know bile stones, we know alcohol, but what are the other causes?
Cystic fibrosis can be there, sir. Autoimmune causes can be there.
Triglyceridemia, hypertriglyceridemia is a very common cause,
Okay.
right?
Okay.
And that can run in the family.
Okay.
Yeah, familial hypertriglyceridemias.
Yes.
So you have to ask for that. What will it? History of MI. No,
I couldn't hear.
that's someone else. Okay, that's it. So you should ask for that. Okay, next slide, please. Okay. Okay, next slide. What are the other problems associated with chronic consumption of alcohol other than pancreatitis?
There can be gastric erosions, esophageal varices, portal hypertension, liver cirrhosis.
And you can have nutritional deficiencies.
Yes.
Right?
Yes.
So you got to look for that. So you got to, in your history, you got to look for that.
Yes.
Okay, next. That's fine. Next. Look, summary is in all caps. Of history is in small. No, these are small details which can tell us about your concentration, commitment to your top. Okay, don't do that.
Sorry.
Next slide. Okay, so anyone, or should we go to the examination?
Yeah. Dr. Ravi, did you ask about any thyroid issues in the past?
Yes, sir. I asked specifically for hypothyroid, sir, because she had gas, early satiety and abdominal fullness.
Is there any significance of hypothyroidism in pancreatitis? See, one of the causes of pancreatitis you told is autoimmune.
Yes, sir.
So there can be associated autoimmune thyroiditis.
Okay.
And you confirm that patient was not aware about her diagnosis in any of her previous admission. Are you sure?
Yes, sir. She used to visit a local hospital. That's what she does.
And okay. Okay.
Should I?
Yeah, you can proceed.
General examination, the patient is conscious, coherent, and well oriented to time, place, and person. Thin build, moderately nourished.
Ravi, I'll come here again.
Yes.
What other endocrine condition can give rise to repeated pancreatitis without the patient or the doctor realizing that this patient actually has a different problem?
Parathyroid, sir, due to
Very
hypercalcemia.
good. Very good. I hope that investigation was done in this patient. Go ahead.
The thin built and moderately nourished, hydration normal, BMI is 17.6, temperature afebrile, pulse rate is 82 per minute and regular rhythm, blood pressure is 100 by 70 mm of Hg in right brachial artery in a sitting position, respiratory rate is 13 cycles per minute, Karnofsky score is 80. Pallor was present, no icterus, no generalized lymphadenopathy, no pedal edema, no clubbing, no koilonychia.
Ravi,
Local exam.
I have one question here. Why did you do Karnofsky score when you don't suspect a malignancy?
It's a general performance score, sir. Just to gauge the severity of the illness, I have asked. I have mentioned the scoring.
I will not agree with you, but it's okay. Go ahead.
Local examination, patient was examined in well-lit room and standing and supine positions, adequate exposure after taking informed consent in presence of a female attendant. These were the clinical pictures of the patients. On inspection, abdomen appears distended. Skin over abdomen shows stria gravidarum. A 2 centimeters trubectomy scar noted in hypogastric region in midline. Umbilicus appears inverted and inferiorly displaced. Fullness noted in the epigastrium, left hypochondrium, umbilicus, and left lumbar regions. All quadrants are moving correspondingly with respiration. Fullness becomes less prominent on head and leg raising test. No visible sinuses or dilated veins were observed. No visible peristalsis or pulsations were seen. No bulges noted in hernial sites. No fullness seen in renal angles. External genitalia, back and spine appears normal. Palpation, no local rise of temperature.
1 minute, Ravi.
Yes.
How do you describe distension of abdomen in a patient? How
Sir,
do you describe distension of abdomen in a patient?
Sir, when we observe the patient from bed level, xiphisternum, umbilicus, and pubic symphysis should lie in the same line. If it appears as a convex, the line gets distorted, it's distended or round.
What is central distension and what is peripheral distension?
Sir, if the cause of distension is flatus predominantly, centrally the bowel loops get distended, sir. If the cause of distension is fluid, then flanks will be full, sir. Hence, peripherally it will
What
be
happens
more.
if there is colonic distension? Which clinical examination will tell you that this is colonic and not small intestinal? When you examine a patient,
Yes, sir.
I want to know from you to judge.
Distal rectal examination.
How is percussion very important in clinical examination surgery?
Sir, if centrally the bowel loops are tympanic, it means small bowel is distended, sir.
Correct.
If the peripherally there is tympanic node, it denotes colonic distension.
It also tells me that you have examined patients in proper way. Go ahead.
Palpation, no local rise of temperature seen, mild tenderness and upper abdomen seen, single 20 into 16 centimeters ovoid lump noted involving epigastric and left hypochondriac regions, extending into umbilicus, left lumbar, and left iliac fossa. This is the borders of the lumps. Extend the superior margin in midline. It is 3 centimeters below xiphisternum. Fingers could be insinuated between the lump and the left costal margin. Inferior margin is 5 centimeters above the mid-inguinal point. Right margin is 3 centimeters from the midline, and left margin is 13 centimeters from the midline. The surface appears smooth, ill-defined borders were felt, firm in consistency, not mobile, no movement with the respiration is observed, becoming less prominent on head and leg raising test. On a lateral tilt test, the lump was not falling forwards. No palpable pulsations were felt over the lump. No organomegaly noted. No other palpable lumps in the rest of the abdomen. Hernial sites were intact. No renal angle tenderness was seen. Percussion, dull note over the lump was seen. Liver span was normal, measuring 10 centimeters in the mid-clavicular line. Dullness of liver is not continuous over the dullness of lump. No free fluid in abdomen is observed, sir. Auscultation, normal bowel sounds were heard. No palpable swellings were felt in left supraclavicular region. Per rectal examination was normal. No significant findings were seen. Systemic examinations, respiratory system, bilateral normal vascular breath sounds were heard. Cardiovascular system, S1 and S2 were heard and no added sounds were heard. Central nervous system, no focal neurological deficits were noted. Summary of case. A 40-year-old female, chronic alcoholic with no known comorbidities, history of recurrent severe epigastric pain radiating to the back, relieved on bending forwards since 1 year with frequent hospitalization, has developed upper abdominal fullness and early satiety for past 3 months, associated with non-bilious vomiting since 15 days with no future suggestive of obstructive jaundice or upper GI bleed. On examination, single mild tender 20x16 ovoid lump noted involving epigastric left hypochondriac regions extending into umbilicus and left iliac fossa with ill-defined borders, firm in consistency, no movement with respiration, becomes less prominent on head and leg raising test, not falling forward on lateral tilt test.
Did you check for the renal angles here?
Yes, sir.
What is there in the renal angle?
Sir, if the kidneys are enlarged, we can probably feel swelling in the renal angles. It is between 12th rib and spines.
If you percuss the renal angle, is it resonant or it is dull?
It is
Normal renal angle.
Normal renal angle is resonant, sir, due to because it is occupied by colon. If the kidneys are enlarged, the colonic tympanic node is masked by the swelling of kidneys.
Okay. Your lump is in the lumbar region, and you have not told us about any bimanual palpation or ballotment.
Yes. Predominantly, the swelling was occupying epigastric regions. If it was arising from central abdomen, I would have checked for bimanual or ballotment.
But you must have told about that, and that is important. The lumbar lump which is there, you should tell about that.
Okay.
Is your lump
Thanks.
pulsatile?
No, sir. No pulsations were felt over the
So in
swelling.
case if you feel a pulsation of this type of the lump,
Yes.
how will you know it is a transmitted one or it is the inside one?
When we examine the pulsations with our two fingers, sir, if the fingers move apart, then it is expansile pulsation, sir. If the swellings remain in the same position, and then it is transmitted pulsations.
Can you apply this one in the abdominal lumps? This what you're telling is the two finger test which is there.
Yes.
That is for the peripherals. Like somebody has
Yes.
a radial artery aneurysm is there, then you
Yes.
can demonstrate that. So in the
Yes.
limbs, if it is there, you can. But in the
Okay.
abdominal lump, how do you know, like, if we suspect it's a aortic aneurysm or it's a pseudopancreatic cyst?
Sorry, sir. I only know about this.
You have to laterally tilt the patient or you have to make the patient in the prone position.
Okay.
If still the pulsations are present, it means it is expansile one. It is coming from the aorta.
Okay.
But if they disappear, it is the pseudopancreatic cyst. So not by two finger test, but by
Later.
making the patient lateral or in the prone position.
Okay.
Now, what external genitalia you have examined in a female patient?
Sir, completion sake.
Usually it is not told.
Yes.
In the males, it is okay that you are
Yes.
telling about the testes. But in the females,
Yes.
probably that is not a very good thing to be
Okay.
told in the.
Okay.
What type of the peristalsis you were looking in this patient?
Sir, for if it is an mass arising from the stomach, for visible peristalsis from left side to right side, I was observing, sir. From right to left, it might be involving the colon.
In the small bowel, what happens? If this small bowel peristalsis is there, how do they look like?
Sir, step ladders,
Which part of the abdomen?
central
Central
step
part of
ladder
the abdomen.
pattern in the center.
Okay. So, do you think this lump which is there is the intra-abdominal lump or retroperitoneal lump?
Sir, but since it is not moving with respiration, and on lateral tilt test is not falling forward, I'm thinking more of a retroperitoneal lumps.
What is the mobility of this lump?
Sir, lump was not mobile, sir. On respiration also, it was not moving with respiration.
Okay. So, what do you think this lump is?
Actually, you mentioned about the tenderness. The tenderness is all over the lump, or it's specific only in the epigastric region, and it's not the rest of the lump.
Sir, specific only in the epigastric region. In the upper abdominal region, it was present, sir. In lumbar and iliac fossa, she wasn't complaining of any tenderness.
Tenderness. Okay.
Yes.
You described that the patient is paler, and
Sir?
you are
Yes, sir.
described the patient is paler. Okay.
Yes, sir.
So it means
Yes.
you have described something. The pathology is related to pancreas, that is of acute and chronic episode, maybe.
Yes. Yes, sir.
Did you check for any other signs in the abdomen?
I didn't. So,
Ravi, I would like to come in here.
yes.
What is stomach bed? How do you define stomach bed?
Stomach bed.
It's an anatomical condition
yes.
which you are supposed to know.
Lesser sac.
What are the organs which constitute stomach bed?
Pancreas, sir.
Yes.
A spleen.
That's far away. This is basic anatomy that I'm asking you.
Yes.
Because all your history contributes to where it is arising from.
Yes. Iota, IVC.
Yes, okay, fair enough.
Kidneys, left kidneys.
Left upper pole of kidney, yes.
Yes.
Somebody is speaking behind the scenes. Thank you. If upper pole of the kidney comes in stomach bed, what
Yes.
else organ can come there?
Adrenals.
Very good. Anything else? It's okay. It's for you to do your homework.
Okay.
Your diagnosis is now pancreatic lesion, possibly
Yes.
a pseudocyst. Correct?
Yes. Yes.
Yeah. Go about investigations.
I would order some routine investigations like complete blood picture, LFTs, serum amylase and lipase for biochemical confirmation of the disease status, ultrasound abdomen and pelvis to see from the anatomical site and to establish the etiology of the disease. And I would order for an
1 minute, Ravi, 1 minute. In ultrasound abdomen, when you ask for ultrasound abdomen of this patient,
yes.
what instructions will you give the radiologist to give you information about the ultrasound characteristics to define and
Yes.
decide on surgery before even asking for a CECT abdomen? I'm not getting to X-ray chest right now. That is
Okay.
a different point of discussion. Before
Yes.
getting into CECT, from ultrasound chap, what do you want? Let's say this is pseudocyst of pancreas.
Yes, sir. If there are any, if it is causing intrahepatic biliary radical dilatation, if the CBD is dilated, or
Biochemistry is normal, I believe.
yes, sir.
Yeah. So there is no indication of asking the sonologist to tell you things about CBD and extrahepatic biliary obstruction. The
Yes,
patient's
sir.
symptom is vomiting. So
Yes,
go ahead.
yes. Should I proceed?
Yeah,
Investigation.
please.
Yes. CECT abdomen and pelvis
No.
to
We are still on sonography, my dear.
yes. Sir, if the patient doesn't have active pancreatitis, if the patient has
Your
gallstones, then
patient, you have described your patient to us very
yes,
nicely. So when
yes.
you send this patient for sonography, what
Yes.
information do you want from the radiology department? That is my question.
Whether cholelithiasis is present
Is that the thing that you're looking for?
to do a lab cholecystectomy.
And leave the cyst in place?
No, sir.
Then tell me, think about things, because I'm really perturbed as how residents are thinking. Patient has come to you with a diagnosis of pseudopancreatic cyst or pseudocyst of pancreas, and you are investigating this patient for recurrent
Yes.
pain in abdomen, recurrent admissions. You have
Yes.
sent the patient for sonography. You want some information. What is the information you would like to have from the radiologist? That is my question to you.
From the site of the pancreatic collection, pseudocysts, sir.
Fine.
Whether it
What
is
in
in
the
the lesser
pseudocyst
sac.
would you 1 minute listen to me? What in the pseudocyst would you like the radiologist to tell you?
Yes. Wall thickness.
Very good.
Whether any internal debris are present or not.
Very good.
Uh, Ductal communication we can't see.
That's fine.
Any air bubbles are present.
What does it tell you?
It tells that there is an active infection,
Okay.
or else the cyst can be communicating with bowels.
If there is communication with the bowel, there has to be some symptom. In this patient, there is no symptom. So you
Yes.
don't expect.
Yes.
What else are you going to look for? Any vascular structure you are interested in?
Yes, sir. Any pseudoaneurysms.
Very good. Anything else?
Any thrombosis,
Of what?
splenic vein thrombosis, or
Very good.
superior mesenteric artery thrombosis.
Now, see, you are unnecessarily talking more than what is required.
Oh, obviously.
Splenic vein thrombosis. If splenic vein
Yes.
thrombosis, what other information would you like to have from a sonologist?
Any gastric varices or
Correct.
esophageal varices present.
And intervention, if you desire to do surgical intervention, you want to do the vascular area where you
Yes.
want to go into. This
Yes.
is the information that USG can give you. Then you
Okay.
ask for CT scan. You have put in X-ray chest in between. I don't want to,
Yes.
this.
Routine.
Now, if you
So,
do a CT scan of the abdomen,
yes.
what are the things that you are going to ask for? Possibly go and see the CT scan in the radiology department, which will
Yes.
give you information whether to operate this patient or not to operate this patient or do something else.
Yes, sir. I would ask them to characterize the cystic swelling, sir. I would see whether it is an whether it has septations, calcifications, uh, whether it is
What
communicating
would
with
you you would only do a CCT abdomen where it or nowadays the machines are good, so you can combine with it MR.
yes, sir.
If you combine it with MRI, how will it change your situation if it shows you a ductal communication?
Ductal communication, we have to address to drain perfectly drain the pseudocyst. If there is an active communication present, then stenting, pancreatic duct stenting has to be done. Then we have to
Very good.
address the pancreatic collections for optimal drainage.
Correct. Very nice. Now, what are the complications of pseudocyst of pancreas which require intervention?
There can be obstructive symptoms like
There are
biliary
obstructive
obstruction.
symptoms already.
Yes, okay, sir. The pseudo aneurysms can be there, sir. Infection
Correct.
can be seen. Rupture can be seen, sir.
Very good.
Ravi,
Yes,
what extra you can see on CT scan over the
yes.
ultrasound?
I can see for any calcifications, sir, any ductal communications, how much caliber the main pancreatic duct is there, whether it is any parenchymal changes like calcifications or fibrosis, enhancement patterns.
First is the location of the pseudopancreatic cyst.
Yeah.
You
Oh,
can
yes,
definitely better localized on the CT scan that what is the
yes.
exact location of that. Because your
Oh,
treatment policy may change
yes.
according to location.
Location.
Then,
Yes.
yeah, what is the size of that pseudopancreatic cyst? What is the wall of
Here,
the pseudopancreatic cyst? And what is it associated with the posterior wall of the stomach? Because
yes,
that can change your treatment. That
yes,
whether the posterior wall of the stomach and the pseudopancreatic cyst wall is matured or not.
yes,
So all these extra things can be seen on the CT scan in a case of a
yes,
suspected pseudopancreatic cyst.
yes.
What is the main differential diagnosis on ultrasound or the CT scan of a pseudopancreatic cyst?
Cystic neoplasias of
Cystic
pancreas, sir.
neoplasm. So how do you differentiate on the
Uh,
imaging studies whether it is a cystic neoplasm or whether it's the pseudopancreatic cyst?
there are specific features, sir, on imaging. If there can be intramural nodule present in cystic neoplasms, there can be septations, there can be peripheral calcifications, there can be in serous cystadenoma, there can be numerous cysts. In mucinous and IPMN, there can be mural nodule. In IPMN, there can be ductal communication, main duct communication, side branch duct communication. Uh,
Can you aspirate the fluid to check for something?
sir,
Aspiration of the fluid can be done.
sorry, I didn't understand.
To check for the markers.
Yes, sir. With using the endoscopic ultrasound, we can go for aspiration, and we can give it for fluid analysis, see CEA levels, amylase levels, and mucin content of the cyst. In pseudocyst, amylase will be increased, IPM and amylase will be increased, sir. Content CEA will be high in mucinous, sir. But depending upon the particular biomarkers, we can differentiate.
Any other investigation you want to do in this patient?
MRCP, I want to see whether it is the pseudocyst is communicating with the duct or not, sir.
Now, in say for example, your imaging shows either
Yes.
sonography or CT both shows the patient is having gallstones.
Yes, sir.
So, will you change your diagnosis from alcoholic pancreatitis to gallstones, or it is still alcoholic pancreatitis?
Since this is an acute pancreatitis case, I would prefer because gallstone induced pancreatitis is more common. I would think about in terms of gallstone induced
Does
pancreatitis
your
rather
patient is having, I mean, is she having a history of recent binge or heavy drinking
no,
prior to
sir.
admission?
Since 3 months, she's
He has been
abstinent.
abstinent,
Yes,
and
sir.
then you find gallstones on imaging.
Yes, sir.
So, will you change your diagnosis, or will you keep as alcoholic pancreatitis only?
No, sir. Since gallstone pancreatitis is more common, I would intervene in that perspective more.
Okay. And see, your patient has never developed acute pancreatitis prior, though she has been
Yes, sir.
admitted, but it was not acute pancreatitis.
Yes, sir.
And this time she has been admitted, and you find a cyst
Yes, sir.
in the retroperitoneum. So,
Yes.
how much time is required for pseudocyst to develop?
It takes 4 weeks for acute pancreatic collection to form a granulation tissue
So
around it
has
and
she
get a
been
organism.
admitted for 4 weeks?
No, sir.
Okay. And is there any imaging, prior imaging available where the pancreatic, peripancreatic collections were there?
No, sir.
Okay. Then how will you justify your diagnosis of pseudocyst? If this is acute pancreatitis, why it
Yes.
can't be only a peripancreatic fluid collection? And why it is pseudocyst?
Because there is a well-formed cyst around the well-formed capsule around the collection.
Okay. Okay.
It differentiates.
Okay. Show CT findings.
Actually, Ravi,
This were,
may I
sir.
intervene?
Yes.
Whenever you are evaluating a patient of pancreatitis, so
Yes, sir.
first thing you have to analyze the cause of the pancreatitis,
Yes, sir.
because you have to take out the cause so that the patient won't have any recurrent episodes of pancreatitis
Yes.
and she won't develop
Yes.
any complications relating to that.
Yes.
Second thing, while doing evaluation, you have to assess the patient is having any local complications and systemic
Yes.
complications. So
Systemic.
your battery of investigations has to
Yes.
be in an order so as
Yes.
to identify all these three things. Then
Yes.
only you can have a better management of these patients. Okay.
Yes, sir.
And from studying your patient, or I
Yes.
mean, taking history, do you find
Yes.
any other specific reason why she has been persistently taking alcohol in spite of recurrent admissions?
Um,
Or is there, I mean, was there any psychosocial issue? Did you able to perceive?
no, sir. Actually, I wanted to know whether she's an alcoholic addict or dependent, but I couldn't get more history regarding it, sir. She like,
Okay, okay, okay. Go ahead.
The ultrasound abdomen and pelvis was done. Pancreas appears normal in bulk with mild altered echo texture with thin rim of fluid around the pancreas. Evidence of 12 into 5.8 into 8.5 centimeters, well-defined anechoic collection with echogenic debris within noted anterior to the tail of pancreas, extending laterally to the left hypochondrium, below to hypogastrium. Evidence of similar lesion of size 6 into 5.2 centimeters noted in left iliac region communicating with the above mentioned lesion. Impression acute pancreatitis with pseudocyst of pancreas. This upper GI endoscopy was done, sir. Evidence of large external impression noted posterior in the posterior wall of the stomach. This is the CT report, sir. Pancreas appears normal in bulk, showing heterogeneous enhancement. Main pancreatic duct measures 3.6 mm and 5.1 mm in body. Wall thickness is 3.6 mm of the cyst. It is extending between left hypochondrium to the left lumbar region, superiorly indenting the posterior wall of stomach, abutting the tail of pancreas, and colon inferiorly, likely pseudocyst of pancreas with mild peripancreatic fluid noted. No obvious communication with the main pancreatic ductus.
How do you actually now corroborate your symptoms of this patient with this report? Pain in epigastric region, radiating pancreas, agreed.
Yes.
Why non-bilious vomiting when the entire cyst is related to the tail of the pancreas? You don't know, you say don't know.
Don't.
Because I just want to bring out that
Yes.
you all don't go to the radiology department to discuss the symptoms. That's the problem. You have one clinical entity on one side and something which the radiology department reports on the other side, which don't coincide. And then you are going to sit and decide the treatment of this patient. That's what I don't like. Go ahead.
This was the EUS reports. An evidence of anechoic lesion noted along the greater curvature of stomach around 9 to 10 centimeters with internal septations. Pancreas morphology couldn't be connected as it is compressed.
Yeah, but tell me one thing. Have you ever gone to with these reports to the patient that my clinical understanding does not match with this patient? Or you just want to operate on this patient? Do you think you will reveal, release the symptoms of this patient? Non-bilious vomiting, will you be able to release that symptom? No. Answer that question of mine.
Since it is
It's
a
okay.
large
Ravi, go
cystic-
ahead. No problem.
that was
If you have to explain about that vomiting which is there,
Yes.
if there is any acute abdomen is there,
Yes.
there's always a reflex pylorospasm is there. A patient of appendicitis, why does it vomit? He vomits because there's a reflex pylorospasm.
Yes.
Okay, so you can explain that vomiting which is there by the
Yes.
reflex pylorospasm. So any acute abdomen can cause it. Even the diverticulitis is there. That can
Yes.
cause the patient present with the vomiting, but it is because appendicitis is there. So similarly, also in the acute pancreatitis also, you can get the patient having the pylorospasm, which is leading to the... So that is the one way to explain about that. Yeah.
Sorry.
Sir, but
It
this
is
is going on for months together. You cannot have pyloric spasm going on every time when a big pseudocyst develops in the distal areas of the pancreas. That is what he is unable to explain, and that is what I was trying to get out of him.
There is no
actually
gastric outlet
your
obstruction in this patient on
Sir?
endoscopy. There is no outlet obstruction in this patient on
No,
endoscopy.
no, sir. No, sir.
and one more thing.
Yes, sir.
Hello. Your blood
Yes, sir.
investigation has to be posted as you posted your imaging investigations. Like
Yes,
that,
sir.
your blood investigation has to be posted because we doesn't know what is the amylase or lipase levels, and you have
Yes.
mentioned parallel and clinical examination. We doesn't know what is the hemoglobin level of the patient, whether the
Yes, sir.
patient has developed any local complications, any vascular complications, and she is bleeding inside. There is no
Yes,
idea
sir.
about that.
Yes, sir.
So that has to be mentioned here. Okay.
Yes.
So whenever we are treating a patient of pancreatitis, initially the local complications, we are about to stabilize the patient. So
Yes.
fluid therapy or whatever, we are about to rush to stabilize the patient first. So for
Yes.
this, we need these basic components to first stabilize the patient. Then we will going for further evaluation, for
Yes.
EUS or whatever thing you need, MRI or whatever thing.
Yes.
First we need to stabilize now. So patient is already having a pain radiating in the back with persistent vomiting. She would be
Yes.
probably not taking proper diet for the past 3 months. So we doesn't know what is the basic homeostasis of the patient. So that
Yes.
things has to be stabilized. So for that, you have to show us the blood investigation reports.
Yes.
Do you have anything in your hand? Blood investigations, amylase,
No,
hemoglobin,
no,
LFT.
no, sir.
See, your patient is vitally very much stable.
Yes, sir.
And say, for example, she is admitted for the first time.
Yes, sir.
Then will you go for CT scan on the first day only?
No, sir.
How will you
Because CT changes will take 48 to 72 hours. I'll initially manage the patient conservatively, then go for CT scan and assess the severity of the pancreatitis.
So that's it. See,
Maybe I can.
by letting us know the biochemistry of the patient,
Yes,
you can you can better judge the acuteness of the problem, and only
yes,
then you should proceed for the investigation, which may have other deleterious effects.
yes, sir.
Here the feeling is coming that it is like you are presenting in a predetermined way, and the diagnosis is fixed. So that should not happen. I mean, you are presenting nicely, but that should not happen. I mean, you have to take into consideration all other factors.
Oh, sorry, sir.
Let's go for the treatment now.
Yes, sir.
What are you planning to relieve the symptoms of this patient of pain, obstruction, and swelling?
Yes. For pain, we she can be conservatively managed, sir. For obstruction, I would like to see treat the patient whether endoscopically or surgically, sir. For endoscopic treatment, I will see whether the cyst is in the near vicinity of the stomach or duodenum, sir. If it is less than 1 centimeter region, I can go for cystogastrostomy or cystoduodenostomy, sir.
Oh, Ravi, see,
This
you are
patient,
already have up to US already you have in your hand. Okay,
Yes,
now
sir.
you answer with
Yes,
it. Don't get whatever in the book,
yes.
cystogastostomy, cystodeonostomy, cystojejunostomy, all things will be explained. But you have
Okay.
this patient, you have the
Yes.
imaging findings, you have done up to endo ultrasound. Now you answer
Yes.
with that. What will you do
I
for
would
this patient?
I would like to go with endoscopic cystogastrostomy drainage of the pseudocystic.
so you have to answer me, how will
Yes.
you relieve the obstruction? You think endoscopy or any other treatment will relieve the vomiting of this patient? I think Dr. Khanna was very elaborate on trying to tell you what happens to the stomach, pyloric spasm, etc., etc. Do you think that your drainage of this cyst, whichever way you take, will
Yes.
relieve the obstruction of this patient?
No, sir, since it is far.
It will.
Yes.
It will. Dr. Khanna has already given you a hint.
Yes.
If
The pain is,
diverticulitis, appendicitis gives you pyloric spasm, pancreatitis
yes.
also gives you pyloric spasm, and
Yes.
vomiting is likely to be relieved, not because of this, but the spasm will be relieved.
Okay.
See, you have to understand the patient as a whole. That is the problem with all of you all, that you don't understand, you focus yourself only on what you're dealing with. But it's okay, go ahead.
Ravi, I think your patient is having a
Yes.
acute exacerbations of the chronic pancreatitis. Okay, the patient has developed the chronic pancreatitis, the pancreatic duct is dilated, pancreas is shrunken. So, you say how much is the pancreatic duct is?
5
3.6
mm
mm.
in the head and 3.6 mm in the
So it
tail
is
region.
a slightly, and what is the bulk is normal.
Yes, sir.
Okay.
Bulk is small.
And now the patient is developing the pseudocyst of the pancreas. Okay. Now this
Yes.
can be either an alcoholic or it can be the biliary. But
Yes.
once you find the biliary thing which is there, then definitely you will think in terms of that is a biliary pancreatitis. So you have to
Yes.
take care of both the things here, the pseudocyst as well as the gallstones also.
Yes.
Okay, so both the things has to be taken care. So if you want to go with one thing which you want to carry out to tackle both the things, what can you do?
Laparoscopic cholecystectomy with laparoscopic cystogastrostomy.
So that only one of your job will be there. You can go
Yes.
for that. Or you can do endoscopic, what you are telling, and separately
Yes.
you will go for the laparoscopic cholecystectomy in this.
Yes.
What is the place of open surgery here? Can we go for the open surgery?
Open surgery, if the in cases of chronic pancreatitis, since according to Diego, class 3, we have to treat class 3 pseudocyst with
Ravi, let me come in here. Don't digress. Now you
okay.
talked of some Diego. Who is this
Yes.
Diego?
He classified pseudocyst basing on the
That is why
ductal
I asked
communication.
you right in advance what is modified Atlanta classification, which you don't know.
Yes.
So now you are digressing, and in the exam, be very careful when you digress from a standardized classification of acute pancreatitis. You
Yes.
start naming people, examiners will come after you.
Okay.
Okay, so be very careful. Okay,
Yes.
I am talking from examiner's point of view.
Yes.
Don't pinch the examiner with names of people. It's
Okay.
extremely dangerous for a student to do it.
Okay.
I'm sure Dr. Khanna and others will agree with me.
Yes. If the cyst is not near the vicinity of the stomach or duodenum, then I would like to go for open surgical drainage, sir. Cystoenterostomies like cystojejunostomy.
Have you ever seen an open cystogastrostomy?
No, sir. I've studied about it.
Okay, you know how it is done?
Yes, sir.
Open cystogastrostomy.
Yes, sir. Upper midline incision is given, sir. Then we do an longitudinal anterior gastrostomy, sir. And we will reach the posterior wall of the stomach, sir, then there will be an bulging sign present on the posterior wall of the stomach. We have to first confirm the swelling using aspiration from the syringe, sir. There will be a turbid fluid. Then, with a circumference of 2 to 3 centimeters, we have to do a gastrostomy, sir, and send the send the sample for histopathology for frozen section. If the frozen
Wait,
section comes normal, then we can do a cystogastrostomy with hemostatic sutures.
if
How
if
big you
if
are going
at
to
all
make it?
now you have said frozen section.
Yes,
If at all it comes tumor,
yes.
now what do you do?
I will go for resection, sir. Resection.
Resection, how you opened anterior posterior stomach and you got into the cyst, and now you got a frozen section report of the tumor.
Yes.
Now what are you going to do? You land up into a big pancreatic resection. See, be very careful when you are answering questions from theory books.
Oh,
My only thing is, be very careful when you are answering such questions. I invite comments from Dr. Khanna and Dr. Ajay. You know, these sort of answers, these people answer and get examiners into trouble of asking them questions and getting then the student into trouble. Can somebody explain this?
When you are suspecting preoperatively,
yes.
it's a patient with a pseudopancreatic cyst, all the features are of that, then usually nobody will go for the frozen section at that time. But if there any suspicion is there, definitely you will go for that. So rather than bringing the frozen section in the treatment of the pseudopancreatic cyst, you should say that we will see that it is a turbid fluid is there. We will make the opening. How big will the opening?
2 to 3 centimeters.
More than that. And a 2 to 3 centimeters is a very small opening which is there. Around 4 to 6 centimeter opening is made in the posterior wall. And then you suture the posterior wall of the stomach with the cyst. Now, why does the food doesn't go in this cyst, in this communication? What is the reason for that?
Uh, Generally, we put the patient nil per oral for 72 hours. So by the time the cyst gets compressed and the drainage of food is by gravity dependent drainage will be there. So there won't be a reflex of food into the cyst.
Now, what complications can occur because of pseudopancreatic cyst?
There can be hemorrhage, sir. Infection can be there. Rupture of the cyst can be there, or obstruction.
Why there should be hemorrhage in the pseudopancreatic cyst?
Because pancreatic collections has elastase in them. When they are released in the
Theory
vicinity, they
book.
can digest
Student.
blood vessels. Since they can lead to the formation of pseudoantigens, and they get ruptured.
If you find it, a patient having the pseudoaneurysm, what is the treatment for that?
We will first go for an angiography and then do an embolization or clipping of the vessel.
What are the methods in which you can do embolization of splenic vessel? You said embolization, right?
Yes, sir.
What are the various methods of embolization?
Coiling can be there or
Yes.
clipping.
Clipping. Anything else?
No, sir.
What is foam
I know.
embolization? What is foam embolization?
I'm not aware.
Very good. That is the best answer to give in an examination. What is double rupture sign in a pseudocyst of pancreas?
A duct rupture signs. Disrupted duct.
Double rupture you have not seen.
No, sir.
Yeah. So I will explain to all the residents who are listening. Double rupture sign is bleed from pseudoaneurysm into pseudocyst of pancreas, which ruptures into the stomach and the patient vomits. So typical presentation of these patients is pain, vomiting of blood, and relief of pain, which occurs intermittently in case of pancreatitis with pseudoaneurysm. Please remember this forever.
Okay.
Okay? Yeah,
Yes.
go ahead. So let us say that this patient has only pseudocyst of pancreas in the distal body.
Yes.
No reason for obstruction, but is obstructed because of continuing inflammation. What will you do?
I'll see for the caliber of the duct, sir.
Duct is normal.
Then I'll go for if it is causing symptoms or anything, I'll go for cystogastrostomy or
Fair enough.
cystogegnostomy.
Correct. You talked of surgical intervention and endoscopic intervention.
Yes, sir.
Which in today's world, if you have got the best of the centers, will you go
Yes.
for endoscopy or will you go for surgery?
According to studies, there is no much
Now,
difference
don't
in.
go into theory again, please.
Okay, sir. I'll go for endoscopic drainage, sir, because hospital
What
stay
stent
and
will you put? What stent will you put?
LEMS. There
What
are
is
two types
Ragi's
of.
net? What is Ragi's net stent?
I only
Nagi
know about.
stent.
No idea, sir.
You have no idea. No problem. Absolutely. How is endoscopic stenting superior to surgical stenting? I mean, surgical drainage.
Yes, sir. There will be morbidity associated with the surgery, sir. Post-operative pain will be less. Hospital stay of the patient will be less.
How do you
Early.
remove? One minute. How do you remove necrosum
Yes.
in endoscopy?
We can do direct endoscopic necrosectomy.
Exactly. So, what instruments do you require in endoscopy to remove the necrosum?
The endoscopy has I forgot the instrument name, sir. It has for holding the necrosum
It is
forceps.
is it rat jaw?
I actually don't remember the name.
Doesn't matter. Doesn't matter. You're not required. This is a surgical GI question. You're doing well. So I am going ahead with further questions. Not an issue at all with me. So let us say this is your patient. How will
Yes.
you treat in your setup?
I'll go for endoscopic cystogastrostomy.
Endoscopic means you want to put in a stent.
Yes, sir. I want to drain
Okay.
the cyst
You
through the.
you want to drain the fluid.
Yes.
Correct. So now what are the avenues for you if endoscopy is not available?
If there is no ductal communication, then I can go for percutaneous stenting also, sir, interventional
Very good.
radiology.
Very
Or
good.
else,
What is your intention is putting a percutaneous pigtail in this?
yes.
What's your intention?
If the patient is frail or infected in sepsis, he can't take the stress of
No, no, no.
endoscopy
There
or
is
surgery.
again you are going back to into theory. Your patient is not
Oh,
in sepsis.
yes.
Your patient is
Controlled
presented to
fistula.
you.
Controlled fistula.
Very good. Very
Yes.
nice. So you put in a pigtail and develop this patient into a controlled fistula, at least presently relieving the symptoms.
Yes.
What next?
I'll see. I'll follow up the patient, sir. If there is no ductal communication, then it has to eventually resolve, sir, and treat
Very
the
good.
etiology of the cause.
Now, etiology of the cause, we go back to gallstone
Yes.
or alcohol. Did I ask you that question?
Yeah, yes.
Did I ask you that question?
No, no, sir.
Then why do you answer?
Yes. Oh,
See, remember, when you are presenting something, you got to be very careful in answering. You are answering more than what is required, which is not required in examination. Remember that. And all the PGs who are listening, just answer to the point and get out of the situation. So you will do a pigtail and convert it into a controlled fistula.
yes.
The next question which will come from an examiner is, what will you do next? Now you answer the question.
Yes. I would like to address the etiology and treat the etiology. If it is
How
an
long do you
alcohol,
think? How long do you think will you wait for the fistula to actually become okay? And will you remove the drain? Think of the patient.
yes. Uh, 2 weeks.
No, it's about 6 weeks.
Okay.
For a fistula to form itself, it will be about 2 weeks. And
Yes.
then you have to wait
Okay.
because you don't know whether there is ductal communication or no. And this.
Yes.
When will be surgical intervention, laparoscopic,
Yes.
robotic, or open,
Yes.
required in this patient to cure this patient?
For my patient, sir. If
Yes.
the cyst is not in the vicinity of the stomach or duodenum,
No,
then
there is no if and there is no if and but. Here we have a
yes,
patient where there is a distal pancreatic pseudocyst which you have pigtailed,
yes,
created a controlled fistula, and now
yes,
you are convinced that I should go in for surgery.
yes. Uh, since the cyst is away from the stomach and duodenum, I would
Correct.
like to do a cystogastrostomy, sir. I will divide
There is no cyst now with that pigtail there. You are left with resection and
fistulojejnostomy.
very good. Who has described it in Indian literature?
Ba. It starts with the D.
No,
No, sir. I have no idea.
it's okay. It's a good answer. No idea.
Okay.
Fistulojejnostomy has been described from Mumbai long time back. I won't like to take the names of people because the person is already dead. So I don't want to get into it. But can you do distal pancreatectomy?
Yes, sir. If there is an disrupted ductal syndrome, then we can. And
There is a disrupted syndrome because the fistula is draining.
yes,
It has not
yes,
resolved.
and the duct is not dilated enough. That is more than 7 mm. Then I would like to go
What
for
is
a distal.
descending? What is descending stream and upstream as far as the pancreatic juice is concerned, according to Atlanta classification?
When there is an disruption in the ductal drainage, sir, whatever distal segment it is there, that is upstream, sir.
So that's why I'm asking you a question. There is a disruption in the distal pancreas,
Yes, sir.
which is causing a problem. What
Yes,
is
sir.
your problem in actually doing distal pancreatectomy?
It has to be addressed by distal pancreatectomy, sir.
Correct. With or
Yes.
without splenectomy?
Without splenectomy, I would do
If the
spleen
splenic
sparing.
vein is thrombosed, if the splenic vein is thrombosed,
If it is causing any varices, then I would like to address.
it has not
Uh,
caused varix, but it will cause varix. Then what?
then I would like to do distal.
So
It is the
whether
surgery of
splenic
choice.
vein is thrombosed or not, distal
Okay.
pancreatectomy with splenectomy is an answer to your
Okay.
question.
Okay.
Intraoperatively, you may put in a stent. That is up to the surgeon to decide. I don't want to get into it.
Okay.
Okay?
Yes.
Thank you.
Thank you.
Other faculty, would you like to give any other questions or comments, sir? Vaibhav, sir.
Oh, yeah, it's fine. I think it is
Shankar,
nice,
sir.
nice presentation.
Ravi, do you have any questions, Ravi, to clarify or any doubts you have before we move on to Sridhar, sir?
No, sir, I don't.
Okay, okay.
Kanagwell, I think it was a good presentation.
Yes, sir.
This boy has presented well,
Yes, sir.
and theoretically he is extremely good. Practically, there is a problem which is their problem everywhere. So I am not going to blame this, because he will encounter examiners who are the newer ones, who will not get into details like Dr. Khanna and Dr. Ajay and me.
Yes, sir.
So he will get out of the situations well in advance. Not an issue. Congratulations to him.
Actually, he is a student of Dr. L. Sridhar, sir. Sridhar, sir is also with us now. Sridhar, sir, would you like to give comments?
Thank you, sir. Thank you for the opportunity given to our boy. How do you rate him, sir?
Sir, my rating will be 4 plus of 5. Others, let seniors tell them, sir. Only thing, he has to be little controlled in uttering statements. That's the only thing I found little superfluous for him. Because examiner expect a particular answer and they are very, very slow and steady and sharp questions come. Circumventing can be reduced. That is the only recommendation from my side, sir.
Okay, sir.
No, I think Ravi has done very well. You know? He has done very well. He has almost answered all the questions. And he probably exactly knew that what is the case he's going to discuss today. So he has done well, yeah.
Thank you, sir.
Yeah, he has done well. Yeah.
Thank
From
you.
my side, I can only say that Ravi and Sridhar sir, uh, clinical assessment of a patient is more important than investigations. And the problem that I have been seeing all the time is the dissociation between different departments and what information we would like to receive from the investigative departments. We don't have a habit of going and actually talking to the radiologist in the department and seeing what we want, because they don't know clinical history, they don't are given clinical history, and then we go and start treating the patient without knowing what is to be done. This is what is lacking in all the systems, education systems, as far as medical education is concerned, which I'm concerned about. But I come into picture only because of Kanagwell here, that
Thank you, sir.
Absolutely, sir.
I take an opportunity.
I
Yes, sir.
totally agree with you, sir, that habit is
Thank you.
lost, sir, in the new generation. But it is
Yeah.
the way now, sir, with this new generation of PGs.
Yeah, sir, but I think as older generation, we should not be actually encouraging this. I go to multiple medical colleges to take lectures or educate people, and its systems have improved. wherever I'm going, at least. So let us get together and convey this also to people, that this is something which I would expect from senior people.
Definitely.
That is
sir.
what is my take.
Definitely, sir. We'll take the message.
Thank you. Thank you, Siddharth. Thank you.
Sir.
And thank you, Ravi. I have very happy news to share. The student who have presented the case last year from Nagpur has got the first rank in the NEET SS. Just now he called up to tell.
Wow.
So thanks to all the teachers. Yash Jain from Government Medical College Nagpur has taken the first rank in the NEET SS results announced sometime back.
Great.
Thank you, students. And at least I've got 10 or 15 messages telling good ranks in 2 digits and 3-digit ranks. I congratulate all the students on behalf of the faculty here. And we wish you all the best in whatever subspecialty you take. And students, all of you who are in the process of preparing for the MS exams or DNB exams, take MCQs also every day as a training, because that is what makes you to get the seat in SS. And on behalf of all the faculty, we wish you all the very best. And we are, in fact, very proud of you. And we are indeed very happy to have had in the PG clinics. Thank you very much.
Kanagwell, can I come
Yes,
in
sir.
here?
Yes, sir. Please, sir.
Yeah, just 30 seconds. I am also extremely proud to announce that I am a visiting consultant and professor at GSL Medical College, Rajamundry.
Yes, sir.
And the first candidate who has won a prize of 1 lakh rupees as IIJ Scholarship Fellowship. And the second one is in the offing, who is online right now. He's hearing me. Only thing, I have to groom him properly.
Who's
And
this?
hopefully, no, I will not name people here.
Okay.
Yeah, the person who won the prize was Dr. Sumant.
Okay.
But the person who's being groomed right now by me, I will not name him, because then, he will go overboard. And he's attending this meeting. So I don't
Amazing.
want to get into it.
Yes, sir.
But we will together see that in IGS as well as your this, we will have good results in time to come, whenever it is available. Thank you.
Thank you, sir.
Good night, sir.
Any other comments,
Thank
faculty?
you.
Can we call a close?
Yeah. Thank you.
Thank you very much, sir.
Thank you.
Thank you.
Thank
Good
you.
luck, Ravi. Please note down
Thank
what
you.
are the areas of challenges and go ahead and refresh your knowledge.
Yes.
Thank you, Kanna sir. Thank you, Vaibhav sir. Thank you, Sridhar sir,
Thank you.
Hitesh sir, and others.